Hello, everybody. We are so thrilled you're here. Welcome, welcome. We're going to get started in just 1 minute. We are live streaming to YouTube for the first time, so we're going to see how this goes. As people start to enter the chat, we're going to get started in just a minute. I am so thrilled that you are here joining us. We have had over 500 people sign up for this awesome, wonderful webinar. So feel free to go in the chat box, tell us who you are, where you're from, tell us what brings you here. And we promise for anyone who hasn't made it, we're going to send the recording. And I'm just so thrilled that you're all with us today. So I'm going to share my screen. And all right, so I am here to tell you that urinary tract infections kill people. They kill people, they cost our hospital system a lot of money, and so many urinary tract infections are due to menopause and hormones. And nobody taught most of your doctors, or if you are a doctor, nobody taught you this in medical school. I am a urologist, and I was not taught this in my residency. And so it is really important that we explain to you why this is so important, why we're doing this. And I'm so blessed to introduce you to my dear friend, my fellowship sister, Dr. Ashley Winter, who trained with me at San Diego Sexual Medicine in sexual medicine. She is a urologist, fellowship trained, and she joined our practice just a few months ago in Los Angeles, California. And so if you are in the DC, Bethesda area and you want to come see us, it's myself, Dr. Kloss, Dr. Christine Vaccaro, and then Dr. Winter is seeing patients in California, which is so extremely exciting. If you don't follow Dr. Winter on Twitter, you must, because she is all over Twitter and teaches this every single day to people and has changed thousands and thousands and thousands of lives, because we teach doctors all the time how important it is to use vaginal hormones in preventing urinary tract infections. So if you are around, please sign up for our newsletter. We promise we don't spam you. We send tons of information about new articles about sexual health and menopause, new events that are coming up, courses that we're speaking at. We really encourage, we try not to spam you. So please sign up for our newsletter. And then very exciting, we have a YouTube channel. And this YouTube channel stemmed from this idea that there are so many questions surrounding vaginal hormones and why they're important. Your patients have questions, you have questions as doctors. And so we have tons of videos of just us answering questions all about genitourinary syndrome of menopause. And so please subscribe to our YouTube channel, watch the videos, share those videos with your patients, because you may only have 10 minutes with them and you say, hey, I really think you should consider this. If you have questions, so many of your questions will be answered with this YouTube channel of these reputable humans who will explain this to you. And so use us to help you educate your patients. And if you are a physician who is watching this, we are doing even more. So this is a free webinar that we're doing, and we will teach you how to prescribe local hormones. But so many of us were not taught how to prescribe systemic hormone therapy in perimenopause and menopause. And so we are actually doing a mentorship series where it is a multi-day, I think it's like 8 different sessions, where we give you information about how to prescribe estrogen, how to prescribe testosterone and progesterone. And it goes through, and we will hold your hand and show you how to write the prescriptions, what pharmacies to use, why it's safe, what's the difference between different types of hormones. So if you are interested in this, I would love for you to register. And we now have CME available if that's helpful for you. So please consider taking this really awesome course. So without further ado, I'm going to introduce my fellowship sister and my dear friend, Dr. Ashley Winter, who is going to start about why this is important and what genitourinary syndrome of menopause even is.
All right. Hi, everyone. I cannot believe there are 110 people listening to this right now. It is amazing. I'm just blown away by the excitement for this topic. Thank you all for participating right now. And I know so many other hundreds of people are registered and will listen to this later. So that's so cool. And as Dr. Rubin said, this is a topic that saves lives, and it is so easy to implement. And this is why we talk about this endlessly. I mean, I have had people through social media say to me that they realize this is so easy and so effective that they are prescribing this from the emergency room, from the transplant infectious disease service, from like primary care, of course, and just so many other disciplines. Or they're, somebody who's not a clinician and they're telling all their friends, and it has legitimately stopped urinary tract infections, made people live better lives. And that's why we are talking about this. So this slide here, right? Vulvovaginal atrophy is kind of what we used to call it. Now we call it genitourinary syndrome of menopause. Really what it should be called is genitourinary syndrome of like low estrogen state, but then also potentially a low estrogen testosterone state. Yes, genitourinary syndrome of low hormone state, essentially. And what is it, right? So a lot of it gets chalked up to vaginal dryness, painless sex. It is so much more than that. And that is because we know not only is the vagina sensitive, exquisitely sensitive to estrogens, androgens, but so is the urethra, so is the bladder, so is the vulva, right? So is the vulvar vestibule, an extremely sensitive ring of tissue right near the opening of the vagina. So low estrogen state or low hormone state can manifest as everything from, right, genital dryness, pain with sex, decreased lubrication, bleeding because you can have tearing and friability of the tissue, burning with urination. It can lead to urinary infections, but also lead to symptoms of a urinary infection when there's no infection, right? So these are symptoms that so often either are ignored, kind of blowed off, like, right, particularly if somebody's coming in, they're like, I feel like I have a UTI, all the cultures are negative, but we actually have tools to solve that, right? And to validate someone's symptoms that they're coming in with and actually fix them. And, a concept that comes up a lot in medicine is like women being complex patients, but it actually just being that they're not having a root cause addressed for them that is particular to women, right? And so instead of somebody going into the doctor again and again and again, feeling like they have UTIs, having a negative culture and being told they're like crazy, being able to validate why they have that symptom and intervene on it and make their life better is like an incredibly powerful tool. And that is one that we have when we kind of know and talk about these symptoms, right? So why do they have these symptoms, right? Well, there are, again, looking at this slide, we can go into it, right? You have so many changes that happen to urogenital tissue when you have reduction in estrogen. So, right, decreased elasticity, the labia minora actually shrink, like they shrink, like you have an entire organ that starts going away, usually 50%, 100%, they just start disappearing, right? Those are protective organs. The vagina gets smooth, right? And when you lose those rugae, then again, sex becomes painful because the rugae exist there to give you ability to accommodate penetration, if that's what you want, right? Of course, tissue fragility, fissures, and that can lead to inflammation, discomfort. So the urethra, right? This is a huge one. The urethra can actually prolapse from a low hormone state, right? It's actually quite remarkable. And you can see somebody whose urethra is just sticking out. And if you start giving them a low dose vaginal estrogen cream, even just dabbing it on the urethra itself, it can completely resolve. It's quite amazing. It's quite amazing, right? That you can just give them a cream and have an organ pop back in. Obviously in very severe cases, that's a different situation. Maybe we do a procedure on it, but in most cases of this urethral prominence, you just give a vaginal estrogen. As I mentioned before, UTIs. So the physiologic basis, right, behind UTIs being related to low estrogen state is that when you have enough estrogen in your vagina, the vaginal epithelial cells produce glycogen. Glycogen becomes the food for a healthy bacteria, right? The healthy microbiome that's supposed to live in your vagina called lactobacillus. And that functions like the probiotic of your vagina. So when you don't have enough estrogen, the vaginal epithelial cells are not making their glycogen. The lactobacillus has nothing to eat. It goes away. And you have taken away the defenses, right? You've disrupted the natural flora. You've taken it away. And the natural microbiome of the vagina just dies, right? And you do not have the defenses you need to prevent UTIs. And this is the fundamental reason why estrogen is so important for UTI prevention, right? And it doesn't have to be zero. It doesn't have to be zero. So it's not, doesn't have to be that somebody has no ovaries in their body or is fully menopausal, right? It just has to be that it's not enough to promote that healthy environment. Also, the vaginal estrogen, because of the lactobacillus, helps keep a healthy low pH in the vagina. So I just like explaining that because so often people say to me, what the hell does estrogen have to do with urinary tract infections, right? We think of estrogen as the hot flash hormone, but it is the UTI prevention hormone. And that connection, when you tell patients, hey, this is your microbiome support, right? This is an actual prebiotic that works, right? A prebiotic, something that promotes a probiotic, a microbiome environment, right? This is one that actually works. Like this is the iconic prebiotic, and people love things like prebiotics. And when you can explain that to them, they will use it, and then they will have the benefits and they will be blown away. I mean, this is the intervention that I have people every single day telling me on social media. I had UTIs every week for years, and now I started my vaginal estrogen and I haven't had any in 10 months or a year or 2 years or 5 years, right? It is amazing. So anyway, on this slide, really important, right? If you look at the guidelines from the American Urologic Association, the number, right, the Canadian Urologic Association, SUFU, right, Female Pelvic Medicine Organization, it is in the actual guidelines to give peri and postmenopausal women with recurrent UTIs low-dose vaginal estrogen because we know it works and we know the physiology of this, right? And I want to point out something in this guideline statement here that's really important, right? Peri and postmenopausal women. So again, I have had women come in suffering with UTIs and they've been told, oh, because you still have menstrual periods, it cannot be hormonally related, but it is in the expert guidelines from urologists, right, that actually this should be offered in perimenopause. So in the period of time, right, we say up to 10 years preceding the last menstrual period, this is a group of people who are suffering and they're still menstruating, okay? And it should still be tried in them, right? So I would say, basically if you have a patient walking in and they're, in their 40s even, and they're starting to have UTIs and this is a new thing for them, maybe talk about perimenopause symptoms and offer them, right? It is so low risk that the worst thing that's going to happen is they try it and it doesn't work, which is much less risky than getting a UTI and getting hospitalized with pyelonephritis, getting multi-drug resistant organisms, right? It's just try it. Just try it. It is in the guidelines. This is not crazy woo-woo stuff, right? It is in the guidelines. So just offer it to that cohort because they especially have trouble getting it. So this is just, an excellent article, published by ACOG, just showing that vaginal estrogen decreased urinary tract infections in half, right? If you look at there's a paper I'm obsessed with. It's in the New England Journal of Medicine from 1993 by Doctors Raz and Stam. You can look at it. That was the iconic randomized control trial, right, of vaginal estrogen. It's actually intravaginal estriol, which is just another type of low-dose estrogen. Works exactly the same way as estradiol, low-dose estradiol. And in that study, right, in the control group, for every 12 UTIs, the intervention group, the estrogen group, had 1 UTI, right? So 12 to 1. And that was in a randomized placebo-controlled clinical trial published in the New England Journal over 30 years ago, right? 12 to 1, okay? That is amazing, amazing data, right? I mean, like, for something that's so low risk, that's been around for a long time, that you could offer almost anybody who has a vagina, that is incredible data. And this is incredible data too. Okay, so as I mentioned before, right, it really is anybody who has a lower than optimal estrogen state in their vulvovaginal tissue. So pre-menopause, right? There's actually a really interesting study that was in, I believe, the European Urology Journal. I have to double check, but it was a really interesting study. Unfortunately, it wasn't a randomized trial, but they actually looked at women in their 20s who had signs of atrophy on exam related to birth control pills, and which can cause a low estrogen state, particularly ultra low dose birth control pills. And in that study, they showed that these women were in their early 20s on the birth control pill, having recurrent UTIs. On cystoscopy, they had bladder inflammation, and they gave them low-dose vaginal estrogen, and their bladder inflammation resolved and their UTIs resolved, right? So it can be used pre-menopause. And if somebody has signs or symptoms of a low estrogen state in their vulvovaginal tissue, no matter what age they are, again, it's such a low-risk intervention. It's worth considering on your differential for why they're getting UTIs. And I use it in so many different groups. So premenopause, right? Genitourinary syndrome of lactation. This is a relatively new term. The amazing sexual medicine research team that Dr. Rubin runs is basically defining this, because people don't talk about it, right? And they're doing research on it and publications on it, and you should look up those publications. But right, we know postpartum that the elevated prolactin levels are associated with decreased estrogen state, and this can lead to genitourinary syndrome of lactation, the same thing, low estrogen state, vaginal dryness, pain with sex, UTIs. Oftentimes women are told, right, that is from birth trauma, or they're not in the mood because they're tired, or some other stuff. And that can all be a component, but it's a lot easier to fix the low estrogen state in the vagina than it is to make your newborn stop waking you up 5 times a night, right? So intervene where you can to help people. And I think a postpartum care gap really is making sure that women are comfortable in the postpartum state. So, and then as we talked about, peri and postmenopause. So throughout the lifespan, don't be a priori saying, okay, because this person isn't menopausal, that they can't benefit, right? Think about it with a little more nuance.
I love the nuance conversation, and how when you know what it's doing and what it's helping, how it's so localized, that there's really, when I teach people how to do this, I say, what are you afraid of? What is the thing you are the most afraid of? There's no cancer risk. There's no blood clot risk. There's no systemic absorption at any measurable levels. It's not birth control. It's not going to stop your ovarian function. And so this idea of what are you afraid of? And honestly, there's nothing to fear with vaginal hormones, which is why Dr. Winter and I have been talking nonstop about this topic for years. We graduated fellowship, gosh, now 7 years ago. You have less gray hair than I do. But this idea is that the more we find out, the more we know how safe and effective these treatments are. It's a no-brainer. And yet so many women are not being offered this life-saving therapy. And so we published a paper recently that said if women got vaginal hormones in Medicare, we could save the government between $6 and $22 billion a year, because of how many people get admitted for hospitalizations for urinary tract infections, drug-resistant infections, sepsis admissions, and death. Think about the nursing home patients. I mean, this is life and death medicine. So you are all here because you want to know how to do this. How can I do this? And it really is basic medicine. You don't need a fancy scanner. You don't need a fancy ultrasound. You need to talk to the patient. And if you can do a physical exam, you should do a physical exam, but it doesn't have to be a speculum exam. You're not doing a pap smear. Now, if pandemic taught us that we can actually do very good GSM therapy through just talking to the patient and the history. And so if you cannot do an exam that first time around, that's okay. Start GSM therapy. You will not harm a patient by starting local vaginal hormones. Now, exams are helpful because they can find major issues. You can find prolapsing vaginas. You can find urethral caruncles. You can find redness and irritation. So exams are always good to do. Now, I have a rule in my office. Everyone gets education when they get an exam, and that we are not mechanics hiding under a hood when we're doing an exam. We don't hide people's body parts from themselves. And so I look at my face in the mirror every day. If something changes, I know right away to talk to my doctor. So when I started our practice about 2.5 years ago, I didn't buy any fancy lasers or any fancy equipment. I got mirrors on Amazon for $7.99. Now I have like 6 of them. So we're really spending a lot here. But every patient gets the mirror. They look at their genitals and we give them a tour of their genitals. So we're teaching as we go. So many of you were not taught how to do genital exams or vulvar exams. And that's why we're here on YouTube yelling and screaming and trying to teach you how to do this, because we know nobody taught you how to look at the clitoris or the labia minora, and so it is really important that you learn how to do new things. So if you're going to do a speculum exam, take 2 seconds to look at the external genitalia. Dr. Winter and I are urologists. We look at penises. We're taught to look at penises, but nobody teaches doctors sort of how to look at the equivalent anatomy, which is the labia and the clitoris and the vulvar vestibule. And so what you will see on exam is that you will see in GSM, genitourinary syndrome of menopause, you can get a flattened labia majora. It can start to look a little bit flattened. You can see the labia minora, the inner wings, shrivel up and disappear. That's called atrophy or labial resorption. This is a normal process that happens as you lose hormones. One of the things that I always say is baby girls have no labia minora. They grow them in puberty and people lose them in menopause. They are hormone sensitive structures. And our research team is actually working on publications on this because we've done very little research as a society of, is this all estrogen dominant? Is it testosterone? Is there something else driving this resorption or atrophy of the labia? No one's looking at this, and it needs to be looked at. You will also see some urethral protrusions on exam. You may see a urethral prolapse or a caruncle, and you may see redness around what is called the vulvar vestibule, which is a really important part of the body that no one taught any of us in medical school. But it is this area that lines the inside of the labia minora that is essentially bladder tissue. It is derived from the urethra, and it is very hormonally sensitive to estrogens as well as androgens. And this is a very important part of the body when we're talking about GSM or pain with sex and things like that. But if you just put a speculum in or you never examine the patient, you won't be able to see these things and really explain to the patient. Because if a patient just says, I have a little vaginal dryness, she may use a lubricant or a moisturizer, but those are not going to fix this problem. And vaginal hormones will. It will fix and heal this tissue, fix this problem, and most importantly, prevent urinary tract infections, which could kill her. So this exam thing is actually pretty important to consider adding to your routine. And we love this. We have pH paper. It's very inexpensive. It measures from 4.5 to 7.5. This is a test you can do. You take a Q-tip, you put it in the patient's vagina, and then you swab the pH paper. And GSM is anything above basically 5. And so we get patients who are dark blue, 7.5. That is not acidic enough to fight infection. In fact, these are the patients who have dryness, irritation, pain, bacterial vaginosis, all of these discomfort. It's not bacterial vaginosis. It is just bacteria that is growing in the non-acidic environment. And so it is really important to show the patients that with use of their vaginal hormones, they're going to heal their tissue and acidify their tissue, and that's how you know it's working. So this is a great thing to have in your office with you, which I absolutely love. So Dr. Winter and I are now going to go through all of the prescriptions that are available to help your patients. I just want you to know many of these have been around since the 70s. Newer options have become available. And I always lecture on this, but this is essentially female Viagra. It existed long before actual Viagra because it helps with sexual function. It helps with arousal and orgasm and lubrication. Like that's what Viagra does for a penis. And yet this prevents urinary tract infections. So vaginal estrogen is female Viagra that prevents UTIs, which is better than, and it was around long before Viagra. We have a marketing problem here because the problem is we've had the products, we've had the data, we've had the research, we've known safety since the 90s and even before that. You're not using it because no one has held your hand and said, this is how to do it, and this is why, and this is your responsibility as a clinician. I see lots of you in the chat box. Some of you are neurologists. Some of you are ER doctors. Some of you are primary care doctors, gynecologists. This is your responsibility to help patients with because nobody else will. We've proven it. We've had these around since the 70s. So I am telling you, you are responsible now because now you know what you need to know to help your patients. So we have a bunch of different products to talk about, ranging from creams to rings to inserts to vaginal DHEA, which is not estrogen. And so one of the things I just want to briefly say is for anybody watching, for any of my colleagues watching who are always taught, just take a little bit of cream and rub it on the urethra. Dr. Winter, please help me scream and yell and to say it's okay to dab some on the urethra, but it's not enough and we need to use enough. What do you have to say about that?
Yeah, what I have to say about that, right, is let's say you had a patient with hypertension and you put them on an antihypertensive, you would recheck their blood pressure, right? You wouldn't just be like, okay, because I prescribed you an antihypertensive, now you are cured, right? And I find that there are people who are prescribed vaginal estrogen and they have persistent symptoms and they're miserable. And they were told, oh, well, I guess it doesn't work for you, or oh, it's something else, or oh, we can't fix your problem. But actually, if you like re-examine them, right, they still have GSM. It's still having the elevated vaginal pH. They still have the lack of their labia minora. They still have all those findings we just talked about. And then it's like, are you not using enough? Are you not applying it the right way? Is it, whatever? Can we figure out an option for you that you are able to remember to use, right? And so we have to strategize, because the same way with any intervention, if somebody's not having the physiologic response we want from the medication, we have to check, right? And again, if you're seeing somebody in a one-off environment, if you're the ER doctor, like we so appreciate you, just start them on it. Fine, great. If you're seeing somebody in a longitudinal environment, it's just so great to actually follow up and make sure that they're getting enough and they're seeing the response to the treatment.
All right, so we are both going to go through each one of these, and we're getting lots of great questions, and there is nuance here. When do you choose one versus another? Which do you do? At the end of the day, any GSM therapy that your patient can afford, will refill, and will use till death does she part is the right GSM therapy. So there are nuances why some may be preferred to others, and we're going to go through that. But the product that is affordable, refillable, and that they will use till death do they part is all that matters. It really is all that matters. And now, so we have to talk about price, because price is when we graduated fellowship in 2017, this tube of estrogen cost $500. Okay, this tube of estrogen, it now costs $13, cash price, no insurance asked. Mark Cuban should be president, in my opinion, because of this one fact that he made vaginal estrogen cost $13, and it lasts about 2.5 months, one tube. So you're talking for less than $10 a month. Your patient without insurance has access to UTI prevention by more than half. So this is a life-saving therapy. So Dr. Winter, how do you describe, so estradiol, this is an estradiol generic 0.01% cream, okay? How should the patients use this cream?
Yeah, I mean, The prescription there is the standard, right? So the 1 gram vaginally, and they can use, again, they can use this insert. If they don't like that insert, they can, they can squeeze out a pea-sized amount. I generally say if they can at least try one time to use the insert, fill it up to 1 gram and squeeze it out on their finger, then they can get an idea of the size of the 1 gram, right? And they're going to use that, right, nightly for 2 weeks, then 1 gram twice a week. I tell them to put it up in their vagina. They don't have to like you don't want to hit the cervix, like you just put your finger in and take it out, and that should be good. Certainly, if there are symptoms that are really predominant around the external like the vulvar vestibule and the urethra, I say kind of split the dose and target that area, rub into the area. And then we're going to reassess, like we talked about before. So we're going to reassess in, ideally 2 to 3 months. And if it's not really benefiting them, then you definitely can go up, right? So that they're using it, let's say 3 times a week if they really need to. So that's how I'm typically having them use it. I don't know. Do you have any other pearls about that?
One tip that I learned. Now, people hate creams, right? Creams can be messy and goopy and get on your underwear and get on your sheets. But if this is all your patient can afford, it's the best option ever. And one of the ways to get around the goopiness or the messiness is, like Dr. Winter said, you put 1 gram on your finger, like up to your knuckle, and put it in the vagina and rub it in like you would sunscreen, right? So rub it in the inside of the walls of the vagina until it is completely absorbed. So that way it doesn't leak out and get messy. This is a great workaround. Just like you tell a patient, you don't put 3 globs of sunscreen on your face and walk out the door. You rub it into your skin until you can't see that white residue anymore. So that's a good workaround. Again, if your patient doesn't like creams, and creams can irritate people, the creams have chemicals in it. This is how they preserve it. The creams can be irritating. There are other options, which we're going to talk about next. But if it's an affordability thing, nothing beats this product. This product is the cheapest on the market. And what your doctor needs to do is send this prescription, what it looks like here, and send it to your local pharmacy and then you show a GoodRx coupon, which you can go to goodrx.com, type in the name of the medication and find where your local pharmacy has inexpensive options. Or they can send the prescription to Cost Plus Drugs, and then Cost Plus Drugs can mail it to you for $13 a tube. So those are 2 really good options to make it affordable for your patients. Again, you want to refill, and you got to tell your patients that this isn't you do it for a month and you're done. It's going to take 2 to 3 months to see maximal improvement, and it will only keep working if you keep using it. So it's really important. Now, one of the first to the market was something called Premarin. Now, Premarin is a conjugated estrogen cream. It is not a generic product. So your patients will be told this costs $400, $500. If their insurance covers it, that's okay. And there are coupon cards, but we often use the last product I talked about, the generic estradiol, because it's so much less expensive. Now, there are some issues about Premarin being made from horse urine. So there are some issues for a lot of us animal lovers out there. And the other thing is this base can have alcohol in it, which can burn a little bit. So it's something a lot of clinicians often use this as a first line. And I would encourage you to stop doing that maybe. And that maybe there are other options that your patients may like a little bit better. And like Dr. Winter said, if they stopped using it, is it because it burned because of the alcohol? Not because there was a problem with the estrogen itself. Any thoughts on this one, Dr. Winter?
Yeah, my main thought, particularly when you have older patients, maybe they're, 80 in their 80s and up, like when you talk about prescribing any hormones, they automatically think Premarin, because Premarin was on the market like decades before everything else. So they don't know there are other options, and they're going to say like, I don't feel comfortable using the pregnant horse product. And just letting them know that there's other stuff that does not involve any pregnant horses is actually something good to just get out of the way and say, because they don't even know that there are other options.
And there are many other options. So one of my favorite options, and that is often covered by insurance, is Vagifem or Uvafem. These are vaginal estradiol inserts. It is a pill that it comes with an applicator and you put it in the vagina. It's 10 micrograms. It's generic and you put it in every day for 2 weeks and then twice a week till death does she part, right? So what is nice about this is it's not messy. It's not, patients aren't so bothered by it. It absorbs by the time they wake up in the morning. It gets that pH down. If you use it, it really will work on the pH. Now, sometimes, like Dr. Winter said, you may want to add a little bit of this cream at the opening around the urethra, around that vulvar vestibule that we talked about. And that's okay to do a pea small size of this every day, but then in the vagina, do an insert twice a week. So these are things that we tell our patients, that we give our patients options. Again, usually insurance is pretty good about covering this. And it is a little bit more costly compared to the cream. If you look at GoodRx or Mark Cuban's pharmacy, I pray that they can get this price down, and hopefully this will be outdated in just a few months or years. Any other thoughts on the estradiol 10 microgram inserts?
No, I love it. I wish it was cheaper.
I wish it was cheaper, and it's very, our patients really do like these. Now, there is a non-generic form of these inserts which don't have an applicator, and they have a little bit of a lubricant inside of it, and it's called Imvexy, rhymes with I'm sexy. I don't think that was a coincidence. And it comes in 2 doses, a 10 microgram like the Vagifem we just talked about, and it also comes in a 4 microgram insert. Now, you do it the same way. You do it every day for 2 weeks and then twice a week. So for your environmentally friendly folks, there is no applicator. So it feels bad to throw away all that plastic. So people like it for that. And then there is, if you send it through Blink RX, they get the coupon cards. And then usually you can get insurance coverage if you can. Obviously, you have to look at price and tell your patients, don't spend $1 million. We can get a tube of estradiol cream for $13. What I will say is the 4 microgram insert dose, it can be helpful for your very estrogen fearful patient. What we can show you in a few minutes from now is that when you use these vaginal hormones, you do not see a big increase any higher than any menopausal levels of estrogen in your bloodstream. 10 micrograms does not increase your blood levels. So 4 microgram definitely doesn't increase your blood levels. So if you have that patient who is an active breast cancer patient who is extremely nervous but is suffering from recurrent UTIs and pain and is miserable, sometimes things like a 4 microgram insert is a nice psychological prescription that can really support the patient. So it's a nice to have, but I wouldn't say it is something I use very regularly in my practice. Any comments there?
Yeah, in general, I think if you have the estrogen fearful patients, and as Dr. Rubin said, we're going to go into how it's all excruciatingly safe. But in general, either the Imvexy or the generic inserts do, on average across the population, lead to a lower estrogen dose than the creams. Not 100% sure why, perhaps in part just due to a more controlled dispensing. So if that is some consideration, really tight control over the estrogen dose, then the inserts are really great for that.
All right, a fan favorite here. This is not estrogen. This one is called vaginal DHEA or Intrarosa. What we didn't go into in much detail is the fact that the bladder, the urethra, the vulva, and the vagina are not just rich in estrogen receptors, but are rich in testosterone receptors too. And here is an FDA-approved androgen product that is used to prevent GSM and to help with pain with sex. We are working on publishing data to show that you get the same UTI prevention benefits with vaginal DHEA. And there's a lovely study by our mentor, Dr. Erwin Goldstein, that shows the use of this vaginal suppository does help with that pain at the opening of the vulva called the vulvar vestibule. So that insertional pain, it can really help with that as well. And so this is a nightly suppository. So as opposed to all the ones we've talked about so far, which is usually twice a week, this is every night. And what I love about this product is that there's no chemicals in this. It is palm oil and DHEA. And so it's very moisturizing and lubricating for the patient. Some patients will say it's overly messy with discharge. I say it's about 10% of my patients say they don't like the discharge, and about 90% love this product. The biggest issue is cost. And so if you can, oftentimes we can get prior authorizations approved because they've tried the estrogen cream and they don't like the discharge. They've tried the inserts, it's too messy, or they're still having pain at the opening. And so we can often get this covered through prior authorization process. That being said, it is $85 a month, which is still too expensive at Costco. So there are different coupon cards that you can use as well. And this is actually one of the few products where they so far give you samples. And so if you are a clinician who can have samples in your office, this is a wonderful thing because they give you 2-week samples. And so the patients can try it before they sort of go through the whole prior authorization process. Any comments on this product?
Yeah, my main comment is one of the main causes, right? And as Dr. Rubin mentioned, was one of the main problems with a lot of these products is irritation. And the irritation doesn't come from the hormone itself. The irritation will come from what we call the inert ingredients, things like the preservatives or the additives, right? And so what you don't want is a patient to have a failure, like, I can't tolerate the estrogen cream, it irritates me. And you don't want to like block them off from decades of benefit because of the inert ingredients. So there are two ways around that, right? You could try something like the Intrarosa, because again, you're talking about really a simple composition, or there's compounding, but of course, compounding is never covered by insurance, and it can also be expensive, and it can be complex to prescribe. So if somebody is having an irritation with their estrogen cream, for example, this is a great tool to have in your toolbox.
Now, we get the question all the time is, can I use both Intrarosa and vaginal estrogen? And I don't think doing both is going to cause harm or problems, but it's also not probably necessary to do both and often cost prohibitive to do both. And so what I say is clinically, we see a lot of the same outcomes. It takes about 2 to 3 months for all these products to maximally work. And they will all only work if you keep if you keep using them. So if it stays in your bathroom drawer, like, it will not work. If the patient said, I tried it for a month and I stopped it, it will not work. And so education is everything when it comes to GSM therapy, which is why I use our YouTube channel to help. We're going to post this. Patients can watch these videos, because the more patients understand the why it's important, the nitty gritty. What if I get a yeast infection? What if it's too messy? Can it get on my husband's penis? Like, these are all questions our patients ask every day. And there will be a YouTube channel with all of these questions answered. So again, we don't usually see a need to do both this and the vaginal estrogen. Although when you think of what are you afraid of, I actually wouldn't be afraid of anything harmful happening. It just seems to be overkill. Any comments with that?
No.
All right, talk to me about the E-string, Dr. Winter.
Yeah, E-string. So this is an amazing product also, right? Again, as Dr. Rubin's saying, the most important thing is that it's a product that they are going to use. And for a lot of people, staying on top of using something every night or twice a week can be overwhelming. And the E-string product, right, is again a low dose vaginal product, does not lead to any significant impact in blood estrogen levels. And you just place the ring in the vagina and it stays there for 3 months and you swap it out. So it is like, so many people love this product. The main problem, again, is cost for a lot of individuals if they cannot get it covered. The patent on it, is it expired? There should be a generic.
It's officially it's generic and available at Mark Cuban's pharmacy, Cost Plus Drugs, but it's still about $500 a ring, which over 3 months is still too expensive. But it is, at least I have had patients with poor dexterity, dementia, where this has been life-saving for their families, and they would have paid any amount of money for it. But sometimes you can get a prior auth through and there are coupon cards as well.
That's a real great point about the dementia. So I get asked all the time by people or nurses that work in assisted living facilities, skilled nursing facilities, or geriatricians, for example, and they say, we can't, it's kind of scary for this patient of mine with dementia to have somebody applying vaginal estrogen all the time, but this is something where maybe they can come into the doctor's office, have a nurse visit once every 3 months, etc., and have it placed. And that can be really life-changing. So that is a cohort ideal use case if you can get it.
Maybe we talk to our Congress people about making this less expensive, because this
Yes.
actually should be less expensive. And hopefully there are people looking into that as well. This is why we're out on YouTube, so that people can innovate and help more people. The last product we're going to talk about, and then we're going to answer lots of questions and talk about safety. Now, this is an oral product that is FDA approved for dyspareunia. It's called ospemifene or Osphena, and it is a SERM, just like tamoxifen is a SERM. Osphena is a SERM that improves vaginal atrophy and the genitourinary syndrome of menopause. It is a pill they take every day. The biggest issue is that when you have a SERM, it is no longer a local therapy. It now is a more systemic therapy, which certainly there is small but not zero risk of things like blood clots and things like that. So this is the one product where I would want to use in an older person, and I don't use in an older person because of the risks. So we do have young people who do not want to put things into their vagina. They don't feel comfortable. My argument for that is, let's get comfortable and let's do some educating and let's work together. But this is an option, and actually works quite well, and really does help with this problem. And so that's kind of I would not probably use it in my older, sicker patients, but it can be a very useful tool. Any thoughts? It's also not always the easiest to get cost-wise. And so and again, $13 a tube of estradiol cream, it's hard to beat the price on that one. Any thoughts on Osphena?
Yeah, again, has all the same benefits of the local treatments. I mean, there's data showing that it reduces UTIs. So, again, all the same benefits. Amazing if you don't want to put something intravaginally. It does kill me that it is associated with systemic risks, such as increased blood clots. So it really, unfortunately, can't get into that population that isn't able to use intravaginal products, which really sucks. So I don't end up using it as much, but it is a great option to have.
There is beautiful data that has been shown that the visual changes of GSM, the labia thinning, the urethra protruding, the redness, the irritation, the things you can see with your eyeballs, if you blind someone to pictures, they can tell who's had Osphena and who hasn't. Now, that study hasn't been done on other products. I bet you that would work too, but it was a very lovely study to show that you can really see the improvements in the visual changes of GSM, not just how the person feels. So that was a very cool thing to see. So I know we're getting lots of stuff in the chat box, and we've been going at this for a while. Put in the chat box, are you learning something today? Are there things that you are actually learning that you can take to your patients starting later today or tomorrow? Let's say some things in the chat box so we know you're listening. So let's talk about some important things that we must get through your heads. I'm going to start here and see what Dr. Winter has to say. Nobody tries and fails vaginal hormones. Like, you can't say, oh, I tried it, it didn't work for me. This is when you really want to think about different modalities and delivery systems. What do you think about that, Dr. Winter?
100% agree. 100% agree. I mean, like I said, the irritation in the beginning, right? Often that's associated with an inert ingredient. You can find them something that will work for them, right? Or it's transient irritation because their body's sucking up the hormone and their friable tissue is like screaming, oh my God, I need this, right? So it's about finding the right option and doing the education. Yeah.
And we have lots of therapies out there: moisturizers, lubricants, overactive bladder medications that cause dementia. We have all sorts of things to offer patients. Why is it so important to start with what I call the foundation, which is vaginal hormones?
Because it addresses the root cause, right? I mean, this is, as you're saying, I mean, this addresses the root cause. So often overactive bladder is from low estrogen state. So often the UTIs are from low estrogen state. Everything else is a patch. This is addressing the root cause. And this is why it is the foundation. So often you will, like you see ads where something's like, oh, replace all your household cleaners with just this product. And they like push everything off the counter and put down this one thing. Like, you could probably push off the counter, right? The lubricant, the moisturizer, the Mirbegron, the, Cipro that you keep taking every other month, like you could push it off the table. The probiotic, that's why this is foundational. It addresses the root cause, and it addresses so many different conditions that we have siloed.
It is the only essential oil that your patient needs, the only one. And it fixes the microbiome. These are buzzwords your patients want to hear. It is so important that you tell your patient and educate them that this is not solved in a week. This is going to take 2 to 3 months for maximal benefit. You do not do a face treatment and regenerate your skin overnight. You do not fix this tissue overnight. Give it time and it will heal. Really, really important for them to know that, because they have to refill it. So how long do I need to take this, Dr. Winter?
Yes, forever. Well, if it's from lactation or other transient low estrogen states, then no. But if it's for somebody in peri or menopause, they should take it forever. As this slide says, when do you stop brushing your teeth, right? Never. You never go to your dentist and say, oh, this teeth brushing has really worked out. I stopped getting cavities. When can I stop? You just don't say that, right? It is prevention. Menopause does not reverse itself, and systemic hormone replacement therapy, if your patient is on that, not all patients are, but if they are, does not have the same efficacy in the local tissue. The data is clear on that. So again, menopause doesn't reverse itself. Systemic HRT is actually a pretty low dose of hormone. This should be on forever.
So if your patient is on a patch or an oral estrogen and they have urinary frequency or urgency, or they get a UTI, you should add vaginal hormones. It does not add risk. It does not add challenges. It does not add more hormones that is going to be too high of a dose. It is separate. So you got to think of the vulvovaginal urinary symptoms separately than the hot flashes and the osteoporosis. So if your patient is on a patch or an oral estrogen, you should still screen, even pellets, you should still screen for this genitourinary syndrome of menopause. Now, we get also, every once in a while, a patient will start a GSM therapy and she gets a yeast infection. And when that happens, I just made a YouTube video, it'll be posted later today. You can't see the top of my head in the YouTube video, I apologize. But when that happens, keep going with the vaginal hormones. What is happening is you take a non-acidic environment and you start to acidify it. And as it acidifies, the yeast can overgrow initially. Treat it, but keep going. Once the microbiome is the way it's supposed to be and fully acidic, we do not see recurrent chronic yeast infections. It is also important to understand that not everything that itches is yeast. I cannot say that enough. You must look at the tissue for lichen sclerosis. You must look at the tissue for irritation and pelvic floor challenges, which can cause itching. And so even if the swab shows yeast, treating it, if the itching doesn't get better, it's probably not yeast. There's probably something else going on. If the vaginal estrogen is good for the vagina, but they still have insertional pain, Dr. Winter, what do you do when that happens?
Well, I mean, as you're talking about here, then you can switch to the vaginal DHEA, right? So we know that the more external you get in the urogenital tissue, the more there are increased density of androgen receptors, right? So androgens become more important. So the urethra, the vulvar vestibule, that tissue all at the opening, super, super sensitive to androgens. And for many people, estrogen does not fully resolve the issue. So the DHEA is going to help that. So this is a great, again, if you don't use it first line, okay, this is a great tool to have in your toolbox, particularly for that.
Okay, my friends, safety information. So we're going to run through some of this quickly, and we will post all of this to YouTube, and we'll send it out the link so that you can have these papers, you know, the safety data, and we'll post a separate video just of this so that your patients can watch this and watch us talk about this. We'll bring on oncologists to talk on our YouTube channel. We'll bring on blood clot doctors to talk about the safety here, but we have to get it through our patients' heads about how safe it is figure out what they're worried about and drown them in the data and have them watch as many videos as they want to until they understand that this is really one of the safest medications that we prescribe. And we prescribe a lot of scary things. Now, the big problem is that when your patient gets home with her vaginal hormones, she opens up the box and there's a big a boxed warning that says that using estrogen causes stroke, blood clots, heart attacks, probable dementia, and must be taken with progesterone. So did we say any of that yet? No, none of that is true. It is all lies. Every single word of this is a lie. It is based on oral, systemic, multi-drug synthetic HRT from the Women's Health Initiative. So this is a completely different medication than what we just talked about just now. It is a blanket statement by the FDA that is in fact harming women because none of this is true. And we have tons of data to show you that I'm going to show you right now that none of it is true. And so this is an advocacy work that we are working on to go to the FDA to fight with them and to get change here because we are killing women by not prescribing these products. Dr. Winter, any thoughts?
Exactly what you said. Nothing else. I guess my only other thing is you have to let your patient know that they will get this insert and to tear it up and set it on fire. Because otherwise they'll say, oh, they didn't tell me about this and it's in the insert and I'm terrified I'm not going to use it, right? I cannot tell you how many people have come to me as a referral, had an excellent initial clinician see them prescribe vaginal estrogen, didn't warn them about this, and the patient never took it. So if you're not going to take it, it's not going to give any benefit.
So first of all, progesterone is not needed with any of these products in the doses that we listed. If you start using vaginal estrogen at much higher doses and the patient has a uterus, that's the one thing to worry about, that you can get some overgrowth in the lining of the uterus. But if you use it at the doses that we told you, you do not need an added progesterone. If you have a patient with no uterus, then you certainly can use the vaginal estrogen at higher doses and not worry about uterine cancer because there is no uterus to deal with at that point. So how about patients that have, let's see, this is a Denmark study that looked at up to 9 years of people on vaginal hormones, and it showed no increased risk of breast cancer of any kind up to 9 years. How about in this paper, I loved this paper, by the way, vaginal estrogen therapy in people with breast cancer. And this data showed not only an increased risk, no increased risk of mortality, but there was a small decrease in mortality in those people who used vaginal estrogen. They lived longer.
Less UTIs.
Less UTIs, less inflammation. They're having more sex, which is making them more active. Like, these are things that keep you alive. This was another paper that showed the safety of vaginal estrogen therapy in women with a history of breast cancer and showed no increased risk of breast cancer recurrence within 5 years in women with a personal history of breast cancer. And why is this? Because there is no systemic absorption of these products. There is not estrogen in your bloodstream to cause stroke, blood clots, heart attacks, dementia, or breast cancer. This study has been done. If look at the left is vaginal estrogen and the right is placebo. There are no lab values here over 16 picograms per milliliter. Men have estrogen levels of 25. So none of these blood levels went above 16 picograms per milliliter. Similar studies with 10 micrograms of vaginal estrogen. It doesn't go 8 hours, you get a peak of 25, and then every other time you check it up to 83 days out, you stay in this menopausal range. In fact, a year's worth of vaginal estrogen, you get 1 milligram of estrogen per year. Doctors give 2 milligrams of oral estrogen a day to help with hot flashes. This is 1 milligram a year. Dr. Winter, when you look at people with a history of other kinds of cancers, endometrial, ovarian, what do they find?
Yeah, it doesn't increase the risk of any of those.
No blood clots, no heart attacks, no problems. This is
interesting data. I believe that if you have like abnormal pap smears, using vaginal estrogen will help increase the risk that your paps become normal. Like It's super interesting. It's super interesting, right? And we know that cervical cancer isn't an estrogen-dependent cancer, but people are scared and they think that all lady part related cancers are fed by estrogen. Not true, but even more so that something about reducing the inflammatory milieu in the vagina and cervix may actually have some sort of protective effect.
All right, we're getting a great question from a neurologist who's asking about blood clots and fibroids and migraines with aura and autoimmune disorders. Oh my, are we going to make all this worse with vaginal estrogen? Dr. Winter, please tell this brilliant neurologist why we don't have to worry about any of those things.
Yeah, great. Thanks. So we don't have to worry about all those things, again, because the systemic absorption is so minimal. Now, if you have somebody who is super, super, super concerned, right? And they're starting with, let's say, the cream or the suppository, which starts as a once a night for 2 weeks, right? You can tell them, let's just start you twice a week, right? We know, like, there are some people who have some sensitivity in those first 2 weeks and they notice minor changes, like some breast tenderness, etc., signs of some systemic absorption. It's not common, but it can happen. So if somebody is super concerned about that, then just have them start at the 2 times a week. It's going to take them longer to like ramp up to get the benefits, but it will still work over time. So again, if somebody's super concerned about that, that is the way to approach it. Another thing I will point out about the migraine with aura is actually that migraine is associated with changes in estrogen and not estrogen itself. So actually, you have plenty of people who have been debilitating migraines while they were, in their reproductive years and menstruating, when their estrogen levels are cycling and going crazy and up and down, right? And then you start them on like a transdermal stable dose of an estrogen, and they don't have migraines anymore. Now, I know the aura component, you're concerned about an increased risk of blood clots. Again, vaginal estrogen definitely not associated with an increased risk of blood clots. So
it's also really important. And if you are a physician and want to take our course on systemic hormone therapy, it's important to know that transdermal estrogen doesn't have the same blood clot risks as oral estrogen. So it's different from a birth control pill. And this is really important. So if transdermal whole body systemic hormone doesn't have a blood clot risk, vaginal transdermal hormones, which are so low dose, do not have an increase in blood clot risk. So it's totally safe to use in anyone with migraine with aura. It is not a strong enough dose to grow a fibroid. And so this is a study that showed people who had a history of blood clots that there was no increased risk of blood clots when you gave them vaginal hormones. And so it's incredibly safe for people with a history of blood clots. So I do want to give a shout out that we are answering all of these questions. We got a question earlier about, is it safe for my husband's penis, Dr. Winter? I love this question and I have my own thoughts. What do you tell patients?
Yeah, so as you mentioned, right, most men are walking around with an estrogen level of around 25, right? So if these are not increasing systemic levels, it's not going to increase his systemic levels, right? Also, the vagina and the vulvar vestibule, you're talking about these mucosal surfaces that are very sensitive to estrogen, right? The penis skin is like dermis, like other parts of your body, right? So it's not going to do any, it's not going to make him grow boobs. It's not going to do anything to him. Like, and on top of that, the vagina will be rugated. It will be lubricated. It will be so happy. And when it's happy, that the penis will be able to be happy. So if anything, the penis will be much happier with the vaginal estrogen. Your husband will not grow boobs. There's nothing to worry about. If you want to be extra cautious, then and probably you just want to do this so that you can save all the estrogen inside of you and not externally. Like if you plan on having sex, apply your estrogen after sex, not before sex, right? But again, nothing scary is going to happen.
So we are going to take all of these questions and make more answers on our YouTube channel. So please check out and subscribe to our YouTube channel. Share it with your patients. It's at Dr. Rachel Rubin. And we are doing a pilot physician a course in how to prescribe systemic hormone therapy. It is a pilot. It is right now. We are just doing physicians, and I hope to open it up to more in the future. It is just my way of dipping a toe here to seeing how good we are at doing this, and I think it's going to be great. But I hope to open it up at a larger audience in the future. This is why we're offering as much free education as we can, and vaginal hormones are something everybody can do and should do all the time in their clinics. And so we want to keep all of those questions coming. So if we can, we will send you, we have a PDF that we're going to send to you of how to write these prescriptions. So you can print it out, keep it in your exam rooms, show your patients, bring it to your doctors. We are really trying to get the word out. So we promise all these questions that you have in the chat box, we are going to make videos over the next couple of weeks. So if you subscribe, we're going to answer all of your questions. And we don't want to keep you here too much longer, but just please remember that sexual health is health, that this is life and death medicine, that people are dying of urinary tract infections and they don't have to be. So please, please, please educate your patients, because this is literally life-saving education. Dr. Winter, any other thoughts?
You will just be so happy once you start doing this. And I would say this was so much information. Do not be overwhelmed. Just take one thing out of this today, and pick that one thing to do. So if there's one medication you haven't prescribed before and you want to start prescribing that, just pick one and start doing it. And you can always come back to this and stepwise increase, but just pick one thing that you are actually going to implement and change in your practice. And you will be thrilled. I promise you. I am not usually a hype man, but this is real shit. So pick one thing, do it. The world will be a better place.
Thank you all for joining us, and we look forward to seeing you on YouTube.
Spain and Armenia, amazing. We've got people from all over the world.